Yes, now we are going to say about the shoulder joint. The objectives that we are going to see in the shoulder joint are introduction. We have to go with the type of joint. Whatever may be the question in case of joint, you have to go with these topics: type of joint, articulating surface, ligaments, bursa, factors contributing stability, and relations, arterial and nerve supplies, movements. In case of movements, there will be in special movements. In case of shoulder joint, we can go with the abduction of shoulder. That is an important thing in clinical aspects. Okay, first of all, introduction. What is shoulder joint here? The shoulder joint is nothing but a joint that is between a head of a humerus and glenoid cavity. We can say that it is a least stable one. Why we can say that it is a least stable? Because the glenoid cavity, which holds the head of the humerus, is too shallow, so it cannot accommodate the whole head. So there can occur a recurrent dislocation, and it is quite unstable when compared to that of other joints, and it easily undergoes dislocation. Yeah, now we have to go into the type of joint. It is in a ball and socket type of joint. Here you see there will be a ball like structure, and the glenoid cavity here acts as a socket. What are the articulating surface? The articulating surface means the bone that is involved, that is a two surface that is getting into a contact. Here this is a head of humerus and the glenoid cavity of the scapula, and this glenoid cavity of the scapula is supported by glenoid labrum. What is meant by glenoid labrum? Let's see into it. The glenoid labrum is a fibrocartilaginous structure which deepens. As it is a shallow one, it has to be deepened. So here you see there is a for deepening purpose. Okay, there will be a structure called as glenoid labrum, and it is usually triangular in shape. Without the glenoid labrum, the glenoid cavity can enclose only one third of the head of the humerus. Okay, so the glenoid labrum makes the head of the humerus to be accommodated, and here the glenoid labrum is continuous with the tendon of the long head of biceps. This is what we have to know about the glenoid labrum. Okay, let's see into the ligaments. What are the ligaments? If a joint, there must be an ligaments, right? Here we can classify the ligaments into two different categories. One is in a main ligament, and the another one is nothing but the accessory ligament. What are the main ligaments? Glenohumeral ligament. Here the name itself represents, yeah, it is between the glenoid cavity and humerus. Coracohumeral, coracoid process and humerus. Transverse humeral, this is what bridging ligament. Let's see into it. And then capsular ligament, that is we can otherwise call it as joint capsule. And then the accessory ligaments, there's two accessory ligaments. One is in a coracoacromial ligament, and the second thing is coracoacromial arch. The first thing, we have gone into glenohumeral ligament. Yes, the glenohumeral ligament, as the name indicates, it is a ligament between two different things. One is in a glenoid, and the other one is nothing but the humerus. In this, there are three thickenings were found in the anterior part of the fibrous capsule. What are they? Superior. You can note into this in the diagram: superior, middle, and the inferior one. These are the three thickenings that is found in the anterior part of the fibrous capsule. Okay, if there is any defects with the superior and the middle thickenings, it may cause anterior dislocation of the joint. This is in a clinical significance over the glenohumeral joint. These joints are visible when we get entered into the joint capsule by crossing the joint capsule or as a capsular ligament. Okay, fine. Next thing we are going to see is coracohumeral ligament. You have to look into the second picture. There is a ligament that is arising from the coracoid process, that is base of the coracoid process, to the anterior aspects of the greater tubercle, right? To the anterior aspects of the greater tubercle from the base of the coracoid process. What is a transverse ligament? I previously said that it is a bridging ligament. Yeah, in second picture you can notice the bicipital groove, right? In the bicipital groove is bridged by a transverse humeral ligament from the greater tubercle to the lesser tubercle. This bicipital groove, in this bicipital groove, the long tendon of biceps, the tendon of the long head of the biceps lodges here. Okay, along with this, we can find a branch of anterior humeral artery. I mean, that is anterior circumflex humeral artery. Okay, and then capsular ligament. The capsular ligament is a thin fibrous layer covering the glenohumeral joint. Yeah, if a ligament is there, we have to go with the attachments, right? In medial side, the capsular ligament is attached to the margin of the glenoid cavity. Beyond glenoid labrum, glenoid labrum, beyond the glenoid labrum, it is attached. It also extends to the supraglenoid tubercle. It also extends to the supraglenoid tubercle. You can find the picture like that. Here you may see this. At the glenoid cavity, there will be two tubercles. Okay, one is superior and the another one is nothing but the inferior. In the superior glenoid tubercle, there will be a long head of the biceps that is enclosed within the fibrous layer. I mean, that is a capsular ligament. For that sake, it will covers the supraglenoid tubercle. What is the lateral side attachment? It is attached to the anatomical neck. Okay, the anatomical neck of the humerus, except the inferior part. In the inferior part, it extends nearly up to 1.5 centimeter or more along the surgical neck of the humerus. Okay, and then we have to see into the structures that is present enclosed inside the tubular sheath. Okay, here what are the structures that is enclosed? Here it encloses an that is a tendon of long head of biceps, subscapular bursa, and the another one bursa is infraspinatus bursa. That is not visible here. The violet color that is represented here is the synovial membrane. Okay, it encloses the tendon of the long head of the biceps that is found in the bicipital groove, as well as here it also encloses the subscapular bursa. It may or may not be enclosing the infraspinatus bursa, and that is found posteriorly. Okay, and if they are enclosing, there must be an aperture, right? What is the aperture here is nothing but an opening. Okay, for this there will be for example, when we are passing a stick into some cloth, there will be cloth is enclosed, a stick is enclosed by means of a cloth, right? So there will be some opening, right? And that particular opening is considered as aperture, as well as subscapular aperture that is present antero-inferiorly, whereas in case of infraspinatus it is present posteriorly. This is what capsular ligament. Now we have gone through four types of ligaments, one main ligaments, four types of main ligaments. What are they? One is glenohumeral ligaments, coracohumeral ligaments, transverse humeral ligament, and finally capsular ligaments. Let me revise once again. Glenohumeral ligament is a thickening. There are three types of thickening that is found in the anterior part of the fibrous capsule. What are they? Superior, middle, and the inferior. Whenever there is a defect with the superior or the middle one, it may causes the anterior dislocation of the shoulder joint. Okay, and this types of ligaments is seen in the interior of the joint. Second thing is coracohumeral ligament. What is meant by coracohumeral ligament? The coracohumeral ligament is extends from, it is in a fibrous band that extends from the base of the coracoid process to that of the, that is a greater tubercle, anterior surface of the greater tubercle. Third thing, that is a transverse humeral ligament. It bridges between the greater and the lesser tubercle, that is in a bicipital groove, in the which encloses the bicipital groove. In the bicipital groove, we have a tendon of long head of the biceps, which is covered by the synovial membrane. When we enter into the capsular ligament, it is in a fibrous layer covering the glenohumeral joint. There is two kinds of attachment. One is in a medial side and the other one is a lateral side. In case of a medial side, it attaches to the margins of the glenoid cavity. Okay, it attaches to the margins of the glenoid cavity. Okay, and then it superiorly it extends up to the supraglenoid tubercle. What is meant by that? Supraglenoid tubercle. So that it can easily encloses the long tendon of the long head of the biceps. Okay, when in case of an lateral side, it gets attached to the anatomical neck of the humerus except the inferior part, where it extends about 1.5 centimeter or more along the surgical neck. Okay, and we have to go on through the structures that is enclosed in the joint capsule and apertures. What are the structures that is enclosed in the joint capsule? That is the synovial membrane encloses in a three different structures. We came to know about it. That is an a tendon of the long head of the biceps and the subscapular bursa, infraspinatus bursa, and then what are the apertures? That is a for each structure that is enclosed there will be aperture. Okay, fine. And then we have to go into the axillary ligaments. What are the axillary ligaments? You see the coracoacromial ligament and the coracoacromial arch. The coracoacromial ligament, that is a ligament that is present between the coracoid process and the acromial process. It provides a protection from the superior aspect to the joints. What is called as coracoacromial arc? The coracoacromial arch, here you see, that is formed by means of three different structures. One is that is the circled one. You get into it. You have an coracoid process, acromial process, and coracoacromial ligament. And these three structures together forms a structure called as coracoacromial arch. Okay, mainly it prevents superior dislocation. It prevents the superior the structures that is present under the this coracoacromial arch is the supraspinatus muscle, which lies very deep to that of the deltoid muscle. The tendon here is, you can see here, this is a supraspinatus muscle. It is very deep to that of a deltoid muscle. So in both sides there will be a deltoid muscles, right? And the tendon of this particular muscle is continuous with that of the joint capsule. Okay, and the another one is nothing but the subacromial bursa. Sub is below, acromial, that is in a coracoacromial ligament, right? So we have to say that it is in a subacromial bursa. And superiorly it is enclosed by means of arch. Inferiorly, in the inferior side, you can see in that picture, in the inferiorly it has two different things. One is a tendon of supraspinatus muscle and other one is greater tubercle of the humerus. These are the structures that is present in the coracoacromial arch. Okay, and we have to go into the bursa. First of all, I told you there are three different bursas that is found. One is subscapular bursa, subacromial bursa, and infraspinatus bursa. Okay, subscapular bursa. The subscapular bursa is found between the, you get into this diagram, you can see a muscle, right? Subscapularis muscle. Okay, it is found between the tendon of the subscapularis and the neck of the scapula, that is in a glenoid cavity, and the continuity of the glenoid cavity you have a neck, right? So there will be a neck, that is a structure that is found between the subscapularis muscle and the neck of the scapula. It gets communicated with the joint cavity. Second thing is subacromial bursa. I have told a lot and lot about the subacromial bursa. What are the relations it might be? You have to think of it, and it is superiorly it is enclosed by means of an deltoid muscles and an acromion process, and you have another one ligament called coracoacromial ligament. Whereas inferiorly it contains the supraspinatus and the joint capsule. Okay, as it is present very deep to that of the deltoid muscle, it is sometimes called as subdeltoid bursa. Okay, the third and the final bursa that is present, each, okay, let it do it here. The infraspinatus bursa, the tendons of infraspinatus and posterol, it is found between the tendon of infraspinatus, okay, and the posterolateral aspect, posterior as well as the lateral, that is a posterolateral aspect of the joint capsule. It may or may not communicate with the joint capsule. What is the function of bursa? It is mainly present between a muscle, okay, and that particular tendon will be in action. To prevent the friction between the muscle and the tendon, there comes a bursa. Actually, the subscapularis bursa is the tendon of the, it is found between the tendon of the subscapularis muscle and the neck. To prevent the friction between the tendon of the subscapularis and the neck, there presents a subscapular bursa. What about the subacromial? We have a muscle called supraspinatus muscle, and I mean supraspinatus tendon will be get into an friction if there is no bursa with the acromion process, right? So if a bursa is present there, that won't be any frictions. Similar way, the infraspinatus muscle too. Okay, we have to get into the relations. I think this is a better way to know. This is a better diagram to know the relations, I think so. You see into it superiorly. What are, first of all, uh, anterior, you the sides is very important. Anterior, posterior, superior and inferior. You just imagine the sides, what is anterior, what is posterior, what is superior and what is inferior, so it might be easy for you to understand what I am going to say. The anterior relations. In anterior relations, you have to come across what are the structures that is present. Deltoid muscle is present anteriorly. Next to it, you have a coracobrachiolis and short head of the biceps, right? That one. And then subscapular wrist muscle. After that, you have subscapular bursa. These are the things that is in anterior relation. Okay, we have to get into the posterior. Posterior, there is a deltoid muscle, infraspinatus, infraspinatus bursa. You include it a teres minor. Four structures that is present posterior. What are the inferior relations? Okay, axillary nerve, posterior circumflex humeral artery, I mean vessels, long head of the triceps. You may include teres major. Okay, these are the structures that comes under the inferior relation. What is the superior relation? We are keep on coming into this. Okay, so you can imagine the structures that is present upward, up to down. First of all, you may face the deltoid muscle, then coracoacromial ligament, then subacromial bursa, supraspinatus muscle. The four structures that is present in the superior relation. Finish. What are the arterial supply and nerve supply? This is another topic we have to go. Arterial supply and the nerve supply. Arterial supply is by means of four different types of artery. That too you have already come across. In the inferior relation, you have posterior circumflex humeral artery, right? I have said previously, in the bicipital groove, there will be a branch of anterior circumflex humeral artery. So that is also involved, okay? Then subscapular artery, and last and the final thing is suprascapular artery. Totally four. Okay, suprascapular, subscapular, two of you can easily remember this by remembering the scapular arteries, subscapular and the suprascapular, two arteries, and anterior and the posterior circumflex humeral artery, they are in parallel. Okay, and then nerve supply as that of artery, you have here three. Okay, one is axillary nerve, subscapular nerve, and musculocutaneous nerve. Okay, you can remember this as MASS. Okay, musculocutaneous nerve, axillary nerve, suprascapular nerve. Okay, in that you can remember they are in pairs: anterior and posterior circumflex humeral artery, and subscapular artery and suprascapular artery. Fine, this is an arterial and the nerve supply. And you have to, as I have said previously, this joint is least stable. The factors provide stability to the shoulder joint, right? Here there are four different factors, okay, that provides a stability to that of shoulder joint. Okay, let me say the factors. Rotator cuff, coracoacromial ligament, long head of the biceps tendon, and then glenoid labrum. Yeah, okay. First of all, rotator cuff. What does mean by rotator cuff? That is a thing that holds something tightly, not tightly. That is makes it hold. Okay, we can the shirt cuff. Okay, wearing a cuff button like that we will say, right? That is in a thickening. Okay, that is in a musculo-tendinous structure. The rotator cuff. This musculotendinous structure is formed by means of four different muscles. You can get into the picture by remembering the fingers: the supraspinatus, infraspinatus, teres major, and subscapularis. You remember the names of the bursa, right? Subscapular bursa, subacromial bursa, and infraspinatus bursa. And these bursa are somehow related to this muscles. You just see into it. Subscapular bursa, that is near to the subscapularis muscle. Supraspinatus, that is subacromial bursa is present here. Infraspinatus bursa is present here, so infraspinatus muscle. Along with this, one more muscle that is present is called teres minor. If you remember the bursa, it will be quite easier for you to mention the names of this cuff. Okay, this will holds the head of the humerus into it, so it will pulls the head of the humerus. You just see in this, it will pulls medially, it will pulls the head of the humerus medially into the glenoid cavity, so it is easier. Okay, this is a coracoacromial ligament, we have came across about it. The glenoid, long head of the biceps tendon. Long head of the biceps tendon is that is processed into the bicipital groove, so that it will also pulls the thing that is medially. Okay, this is the long head of the biceps tendon. And then the glenoid labrum. The glenoid labrum, as the glenoid cavity is too shallow, so in case to deepen the glenoid cavity, the glenoid labrum is present, so the muscle bone that is the head of the humerus will get attached better. Okay, and then movements. Here there are four different types of movements: flexion and extension, adduction and abduction, medial rotation and lateral rotation, and finally the circumduction. Yeah, we came across these terms. Now you just see what is the plane and what is the axis of each and every movement. Flexion and extension, you just do it. Flexion is towards the sagittal plane, that is in a cross section, sagittal plane. The axis is frontal axis. And then adduction and abduction, that is exactly opposite to that of the flexion and extension. Okay, that is they are perpendicular to each other. So frontal plane and the sagittal axis, medial and the lateral rotation. Here the plane comes as transverse and the axis is vertical. The circumduction is combination of all the three movements. Okay, that is here the abduction of shoulder. Okay, the abduction of shoulder is well given here. Okay, the abduction of shoulder is usually taking place at different places, and the muscles involved is totally different. Initially up to 15 degrees. Okay, it takes place in the shoulder joint. The muscle involved here is supraspinatus muscle. 15 to 90 degree, this also occurs in the shoulder joint. Here the muscles involved is middle fibers of the deltoid. 90 to 120 degree, it does also occurs in shoulder joint. Along with this, the lateral rotation of the humerus occurs. Why? What is the need for the lateral rotation of the humerus to occur here again? Whenever you lift, I mean abduct your hand, there will be a greater tubercle, right? This greater tubercle will come into a direct contact or impinge the acromion process, so that we can't abduct further unless we do the lateral rotation of the humerus. So here the lateral rotation of the humerus occurs, and the muscle here involved mainly is two different things. One is the infraspinatus and the teres minor. And the here 120 to 180 degree, actually it is classified into two subdivisions. Okay, this 120 to 150 degree happens by means of two different things: scapular rotation and clavicular elevation. Okay, here the clavicle joints that is involved in the clavicular elevation is acromioclavicular joint. That's what I mentioned as AC joint. Okay, and then the muscles involved here is upper fibers of trapezius and levator scapulae. and the last and the final rotation, that's the extension. Here also occurs the scapular rotation, and the joint here involved is sternoclavicular joint. Here, the muscles involved is upper and the lower fibers of the trapezius and the lower 5 digits of the serratus anterior. One more thing, here the humerus and the scapula is moves in the ratio of 2:1. For example, for elevation of 15 degree, the humerus moves 10 degrees and the scapula moves 5 degrees. Okay, you can understand what I am trying to say. The humerus and scapula moves in 2:1 ratio. Okay, 2:1 ratio in abduction. For elevation of 15 degree, humerus moves 10 degrees and scapula moves 5 degrees. And okay, this is what moments, and we will get into the clinical importance. Okay, the most important clinical importance that is we often come across is dislocation of the shoulder joint. Okay, the mostly it occurs inferiorly. The dislocation occurs inferiorly. Why? Because there is no support from the inferior side. In superior side, there is a coracoacromial arch. Am I right? Yeah. Coracoacromial arch is present superior. Whereas the inferior aspect, there is no support at all. So the inferiorly, the dislocation occurs easily. With reference to the infraglenoid tubercle, okay, I have shown you a picture here. In this, you may note an infraglenoid tubercle and the long head of the biceps. With the reference to these structures, we can say whether it is antero-inferior or posterior-inferior. But most probably, we will come to suffer in antero-inferior one. Okay. Uh, on seeing that, we can identify whether it is in a dislocation or something else. If it is in a dislocation, there will be in a hollow round counter in the shoulder. You can see there will be some depression. There is in a hollow round counter, or you may see the prominence of the shoulder tip. Okay, this is a dislocation. In this dislocation, particularly we can say the Bankard lesion. This is what the glenoid labrum will undergo steer in the antero-inferior part. Okay, via this the humerus will comes out. Okay, and this will occur recurrently. By pushing the head of the humerus, it will get back into its normal position as that of hernia. When to reduce the hernia, we will press it so that it will get back into the cavity. Similarly, here also the humerus will get ouch. It will come out through the tear that occurred in the antero-inferior layer. But whenever we push the humerus, it will get back into it. Okay, this is Bankard lesion and frozen shoulder. This frozen shoulder is nothing but it has a severe pain and it will limits the movement. Okay, it will limits the movement, whatever may be the flexion, extension, adduction, abduction, circumtension, medial rotation, lateral rotation. These all type of movement has been limited. But when we go into an X-ray or something else, you can't find any abnormality, and this is called frozen shoulder. This is why, because the shrinkage of the joint capsule. Okay, this occurs in the age group of 40 to 60 years old people, and you have to. This is another one disorder that is called rotator cuff disorder. Okay, in this rotator cuff disorder, specifically we will come across the calcific supraspinatus tendinous. Okay, this rotator cuff disorder will come only when there is a repeated usage of the upper limb, okay, above the horizontal level. For example, the persons, those who are swimming, weightlifting, and any that is a heavy objects to be lifted or something else like shot put, these games people can suffer from this disease. Okay, uh, as a result of this, the supraspinatus tendon, right, that will get deposited by means of an calcium. This causes irritation to the subacromial bursa. As a result of it, thus there occurs a subacromial bursitis. Acromial bursitis. Here there is an inflammation. It is means inflammation. Yeah, we know that. When abducted, this bursa will caught between the tendon and the acromion process. So acromial impingement, it will get into it, so it will causes a severe pain. Okay, this will happen, I mean, that is another bursa will get into the tendon, between the tendon and acromion process will occurs mainly in the degrees, that is 60 to 120 degree abduction. And this will happen in the male after 50 years old. Okay, uh, to identify this disorder, okay, there is a sign, okay, that is called as Barnes sign. In case of adduction and abduction, when in adduction, when pressed below the acromion process, you can find this that picture in the radiological one. There is a calcium deposition, right? When we press that, okay, that is below the acromion process, it will causes pain. But in case of an abduction, that bursa I said previously, right? That bursa will get into, I mean, it will be caught between the tendon and the acromion impingement, so there won't be any pain by pressing at the same point. Okay, this happens. This is called as Darwin's. And thank you for all to hearing my words. Okay, fine, thank you.